Great. Thank you so much, Devin. And thank you all for joining today. Welcome. It is an absolute pleasure to welcome you all today. This is our first webinar in the COVID era. It took us a year to get here, but I'm so happy that we are finally doing this. And what I wanted to do today was just sort of give you an overview of myeloma and other plasma cell disorders to start out with, and then you're going to have different folks kind of talk about different parts of your myeloma care over the next 1 hour or so. As Devin has pointed out, we are going to have a panel discussion towards the end. So we're going to save the questions for the end of this program. So use your chat function, as she's already mentioned, and put in your questions. We're going to try and get to as many questions as possible during the course of this broadcast here. So what I wanted to just highlight, one is, before I get started, I just wanted to give a huge shout out to all of you. This has been an exceedingly difficult year for everybody, and I wanted to thank you all for your patience, for the changes we've had to make during our program where we have not allowed visitors. You've all complied. We've had challenges with scheduling, but all of you have stepped up to your to the challenges and really put up with the challenges of the pandemic that we've had to deal with. As you all know, our mission is always to provide the best sort of care in a very patient-centric way. We do a lot of laboratory work, and I'm going to share with you some of that as well. And the ultimate idea here is to create a platform for curing these plasma cell disorders in the future. I just wanted to introduce you to our team, and out here on this slide is just the clinical team which you interact with when you come to the clinic. We have, you're going to hear from Andrew Branagan out here, you're going to hear from Betsy O'Donnell later on, and Andrew Yee. These are the clinicians. We have fantastic nurse practitioners, Emmy, Cindy, as well as Jill. All of you know them. Bridget is somebody who helps us with all of our pharmacy needs. And then we have an amazing research team wherein we have Kathy, Madeline, as well as Lisette, who help us with the research forefront. And then we have a bunch of clinical research coordinators, Isabella, Becca, and Zach, who are part of the team. This is just the team which is on Rocky 9. There's a lot of people behind. I'm not showing you the laboratory folks. And then we have a multidisciplinary approach where we work with radiation oncology, orthopedics, and so on and so forth. So it's a real team behind the care of your myeloma. Last but not the least, I think the most important person in our team is Lovely, who really keeps us all on track and on schedule. So with that, I just wanted to sort of give you an overview of myeloma. As you all know, this is a hematologic cancer. It is not an uncommon hematologic cancer. Most of you, before you have myeloma, have never heard of myeloma. But if you think about myeloma, it is actually the second most common hematologic cancer, occurring in more than 30,000 people. And there's different ways of diagnosing. I think all of you are familiar with this. And what's happened over the last 20 years now is there's been a lot of progress in drug development. And we have all of these different classes of drugs, which you're going to hear about from Betsy, from Andy, and Andrew over the course of this 1 hour, which has really made an impact and made a difference in how we take care of all of you. So can you guys hear me? I was muted for a second. Sorry. So the goal out here is obviously to create a strategy to cure multiple myeloma and the other plasma cell disorders like Waldenstrom's. And the question really is, are we there yet? I'm not so sure, but I do think we are at a threshold where we are at a transformational state in the context of myeloma, where we have all of these treatments. And I do believe we have actually made the disease very chronic, which is the first step towards cure. What we do try and study in the lab as well as in the clinic is what are the factors which define cure and what are the limitations of getting to that cure. And some of what you all participate is in answering some of these questions. And the question really then comes up is, if we want to cure disease, should we be treating it really early, and should we be treating asymptomatic disease? Well, we are already doing this. This is just a whole host of different clinical trials that we have in the space of smoldering multiple myeloma. So I'm sure we've talked to you about this. I'm not going to go into the details of this, but the point here being, creating a curative platform would be trying to address this disease early on in the course of the disorder itself. Multiple myeloma, as you all know, is a fairly complex disease. This is something which we study in the laboratory. We know that multiple myeloma is impacted by a whole bunch of other factors, and that is the point of our studies in the laboratory. And from this, we are able to identify different targets and as to how to get better control of this disease. So understanding the tumor cell is an important aspect of what we do in the laboratory. We've already done exome and genome sequencing in multiple myeloma patients. And over the last several years, we've been able to identify the genetic underpinnings of this disease. What we've also done, and I think most of you are familiar, when the disease does come back, we do repeat bone marrows. And what we're looking at is not just genetics at the starting of myeloma, but tracking this genetic heterogeneity over time. And the important thing that we've learned over time is, instead of using bone marrows, can we use blood? And this is again a research protocol, but the future really would be using a blood biopsy instead of subjecting you to bone marrow biopsies in the future. Obviously, myeloma is dependent, as I've mentioned, on a whole host of other cells. It is very microenvironment dependent. So part of what we do in the laboratory is try and understand this microenvironment. And we do a lot of work around bone disease, for example. So understanding the bone cells, understanding adipocytes, understanding immune cells is a part of what we do in the lab. With all of this, we have a lot of new stuff in myeloma, which you're going to hear about from Betsy, Andrew, and Andy. So I'm not going to highlight any of this right now, but we have all of these different classes, which is going to help take care of your disease. So I think in terms of where we are in the context of these plasma cell disorders and specific myeloma, we know that when the disease comes back, it still remains an unmet medical need. And we're doing everything in the laboratory to try and understand this and to try and improve on what we already have. We are using drugs with different sort of mechanisms of action. We're combining different drugs. And with that, we are seeing really deep responses and very durable responses, as I mentioned, which would be the starting point to transform a disease into a curative platform. With the tools we have in the laboratory now is that we are able to identify high-risk disease as well. And by doing so, we can specifically target different populations depending on the genetic risk or the high-risk features of those specific patients. And excitingly, I think you're going to hear about immune strategies later on in this program, where I think we're just at the beginnings, we're just at the early stages of immune strategies, and we still have to really identify the power of these immune strategies in really harnessing all of these plasma cell disorders. So I think we are in for a very exciting time in myeloma, and our goal is to search for novel targets and really transform the chronicity of these disorders into cure. In the last several minutes, I did want to touch on COVID-19 and myeloma because I think that's on top of everybody's mind. And I think it's impacted each of us either personally or in some way we've been connected to COVID-19. As I mentioned early on, we are extremely grateful to all of you for your flexibility during this pandemic and how we've had to take care of you, how we've shifted over to Waltham, wherein Jill and Andy Branagan have done a tremendous job of setting up our clinic there, where we've been able to see patients. Andrew has done it at Danvers as well. So thank you for your flexibility. We're going to talk a little bit about COVID-19 and we'll get to vaccines as well. As you all know, SARS-CoV-2 is an RNA virus. We first had this reported case in Seattle in the United States literally a year back, January 19th of last year. And COVID-19 illness, I think all of you are familiar with: fever, cough, shortness of breath. A lot of you have called into clinic, and we have Kat, our practice nurse, who will then triage you to sort of get COVID tested. So despite the fact that we've had the pandemic, obviously myeloma and Waldenstrom's doesn't stop in its tracks. Those diseases continue, and we've had to make some changes in how we take care of you. But we've done testing, we've created strategies in the cancer center so that we can still continue to provide care. This is just the status of COVID-19 in the United States. 27 million patients with close to 500,000 deaths, unfortunately. The good news, though, is we are seeing a decrease in the number of cases, and we're also seeing a decrease in mortality. Certainly in Massachusetts, we're seeing that trend, but all over the United States, we do see a trend which is going down. And we do hope that with the vaccination, there's going to be a turnaround with all of these statistics as well. So the big question is, do cancer patients with COVID-19 do a little bit worse? And the answer to that, if you look at all comers of cancer, the answer to that is absolutely yes, which is why I do think prevention is the best strategy when it comes to COVID-19. When it comes to multiple myeloma specifically, we have actually studied this, and unlike, like all other COVID-19 risk factors, I think the same risk factors apply for myeloma patients as well. So having comorbidities, renal disease puts you at a slightly higher risk. But I think the biggest thing that we have learned with plasma cell disorders is suboptimal control of the disease actually predicts a worse outcome, which is why we shifted very quickly in trying to continue to provide the care that we could during the pandemic as well, because I do think this is a really important feature. So when it comes to management of patients with plasma cell disorders in the era of the pandemic, we have a whole lot of bodies like the International Myeloma Society, the American Society of Hematology, and it's not one size fits all really. One has to kind of tailor therapy to the individual patient, which we've been able to try and do. I think the big takeaways is during this global pandemic is control the disease as best as you can. If there are situations where you can put people on oral medications, absolutely, but otherwise do not compromise the care of your myeloma even during this pandemic. Coming to the vaccines now, there's a whole bunch of different COVID-19 vaccines. We're only going to focus on the RNA vaccines and the viral vector-based vaccines because those are what we have in the clinic right now. We're never going to use live attenuated vaccine, not in the context of myeloma in any case. So as you all know, the BNT162b1 is the Pfizer vaccine. This is an mRNA-based vaccine. It's already got FDA approval, and some of you have probably already received this vaccine. There's another mRNA vaccine from Moderna. Both of these require 2 shots, one 3 weeks apart, the other 4 weeks apart, and either of these 2 vaccines affords you an immunity of at least 94% or so. So when it comes to vaccination, it doesn't matter which vaccine you're getting. Our recommendation for these mRNA vaccines is take the vaccine. During the panel discussion, we're going to talk about certain situations and what do you do with your drugs when you're getting those vaccines. We'll address those during the panel discussion. We just heard about the Janssen vaccine as well. The data for the Janssen vaccine is out. It's a little bit different from these mRNA vaccines. This is a viral-based vaccine, but it's still going to be extremely safe in myeloma patients. The difference here is it's a single shot, and it still affords immunity of more than 65%. And the important thing to remember with the J&J vaccine is it reduces severe infections by about 86%. So during the pandemic, I do not think we're going to have a choice of which vaccine to use. Whichever you have access to would be the recommendation for most patients to get. So again, I think more discussion during the panel. So the key takeaways for COVID-19 is the risk of infection in myeloma is not any higher than the general population. However, depending on where you are with your myeloma, the outcome can be different, and therefore prevention is probably the best strategy going forward. So vaccination is something we're going to be doing in the majority of patients. So please say yes to vaccine when you're offered it. Andy Branagan is going to talk about vaccine and a study which we have ongoing later on in the programs. The vaccines certainly are safe, and there should be no situation wherein you should not be getting the vaccine unless you have sort of an allergic reaction. So I think I'm going to stop there, and I'm going to, this is just the whole team. I just showed you the clinical team earlier on, but we have a really fantastic laboratory as well as a clinical team behind you in your fight against these diseases. And I'm very grateful to everybody who's been a part of this. So with that, I'm going to actually turn this over to Betsy O'Donnell. Betsy O'Donnell is also the director of our lifestyle medicine program, and she's actually created that program. So those of you who are interested in lifestyle medicine, reach out to Betsy. But Betsy is going to walk us through newly diagnosed myeloma and what's new and what's happening in this space right now. So thank you, Betsy. It's all you.
Thank you, Noopur. And if you'll just go out of your screen, I'll come into mine. Great. All right. And so thank you so much for the introduction, Noopur. And I too want to thank everybody who's joining us today just for your ongoing support, courage, and fortitude through this very long year. We appreciate it. We particularly appreciate the caregivers. It's been so challenging not to be able to have caregivers in clinic. So want to acknowledge you as well. So today I'm going to be talking about the management of newly diagnosed multiple myeloma. As you know, treatment for myeloma goes in phases. And so I'm going to begin with an overview of treatment for myeloma. I'm going to talk specifically about some data that was presented at ASH this year about the use of 4 drugs in combination in the upfront setting. And then I'm going to touch on a topic of minimal residual disease and the future uses of MRD testing as we think about ways to better manage myeloma. As Noopur said, our #1 goal is trying to cure multiple myeloma, or at least some decent % of the population. And so different strategies of how we can first take our first shot at it in the newly diagnosed setting is one very important factor. But then over time, as this can be, a chronic cancer, how can we tailor therapies, and can we use tools like minimal residual disease to do that better? As Noopur alluded to before, there's been tremendous development of drugs. This is a timeline of drug development in multiple myeloma. And you can see in the past 5 years, the number of drugs that have been approved by the FDA for the treatment of our disease. And that number is only going to increase in the years to come. Not only that, we have new ways of treating myeloma that really are on the forefront of approval shortly. When we think about the components of management and the traditional paradigms of how we treat myeloma, there are 2 general buckets. Anytime we make generalizations, however, we know that it's not a one size fit all, but historically we talk about patients as transplant eligible or transplant ineligible. Eligibility historically was based on age. Patients under 65 are transplant eligible, over 65 not. Many people in this room are under 65 and haven't had a transplant, and there are those over 65 who have. So these are broad generalizations. The reason I bring them up is just to frame the discussion that will come forward. Everybody undergoes therapy with a combination of drugs. Right now, our standard of care is 3 drugs. Sometimes we do 2 in circumstances. For patients who won't go on to have a transplant, they continue on that therapy, usually for at least 8 months, and then go on to maintenance. Patients who are going to have transplant usually will do something for about 4 months of induction, collect their stem cells, have a transplant, receive additional therapy afterwards to consolidate, and then go on to maintenance. We typically use combinations. The purpose of this slide is not to talk about those combinations, but really visually to show you how over time the response rates, which are blue, and the types of responses, the orange is complete responses, how those have gone up over time. We continue to work at this. We started with older drugs, with 2 drug combinations, and we've built year in and year out on adding drugs, changing the classes of drugs, with the goal of getting that orange bar all the way up to 100%. And what are our goals of therapy? To improve organ function. Sometimes people have problems with their kidneys or their bones. We want to use treatment to make those better. If patients are in pain, our treatments can help mitigate the pain, relieve other symptoms. We want all of our patients to maintain activity and function and have the highest quality of life possible. I speak for all of our providers in our group when we care very much about your quality of life and wanting to really make your experience the best that we possibly can. And we want to control the disease. The deeper the response that we can get, the better. We know that. When I talk about minimal residual disease later, we know that getting to the lowest disease state possible improves patients' overall survival and that period of time where they're in a remission. We can get to an MRD state in patients who don't undergo transplant. We know this. But with all of this, and I think part of our discussions, we see, as you know, we see a lot of each other. You're in almost weekly, particularly in those early phases. And we're always trying to work with you to balance quality of life and toxicities of treatment to get those deep responses. As doctors, when we're picking a specific regimen, there are a lot of factors to consider, and this is true in all myeloma. Age is a factor. Frailty, meaning how strong you are, what other medical problems you have. As you know, anybody who's taken any therapy for myeloma knows that for every one treatment we give you another pill to go along with it to mitigate a side effect. So how those interact with each other is important in our decision making. If you've had other medications before or drugs, how you've done with those. And then we look at the disease factors. Part of what Noopur showed was that molecular profiling, the cytogenetics. What kind of myeloma do you have to the extent that we can understand it? And then what are the other specific toxicities if you have other medical problems or out-of-pocket costs when doing oral regimens? And we put this together and we really try to do personalized decision-making. We also talk amongst ourselves at our tumor board that we have every week about how to best care for our patients individually. And, there's always this balance between is less more, is more less. If something is highly toxic but has a greater efficacy, does that really outweigh the benefit of being able to stay on something at a lower dose continuously? And some of the work that we've done, and in particular RVD Light, is a regimen that demonstrates that we can achieve equal efficacy with lower doses by virtue of helping people to stay on the treatments continuously. So before I build, I'll start with where we are. So what are the kind of most common upfront regimens for transplant eligible patients? The combination RVD, Revlimid, Velcade, and dexamethasone is our benchmark. KRD, carfilzomib, Revlimid, and dexamethasone is another alternative to that. And then Cyborg, where we substitute Cytoxan with Velcade and dexamethasone, is a very useful and effective regimen. And very often this is something we can start if someone is sick and in the hospital or having problems with their kidneys. For transplant ineligible patients, RVD Light was pioneered here at MGH. And like I mentioned before, is those same combination of drugs at a slightly different schedule with slightly lower doses that achieves similar efficacy to the higher dose regimens without the toxicity in older patients. Daratumumab, which I'll be talking about momentarily, is a monoclonal antibody that can be used very effectively in combination with Revlimid and dexamethasone, and again, Cyborg. So I'm going to talk about daratumumab, in particular, a presentation that was done at ASH, which is kind of our high holiday in multiple myeloma. It's our big conference every year in December. Daratumumab is a monoclonal antibody, so it's an immunotherapy. It works by binding to a specific protein that's on the surface of plasma cells called CD38, and then it activates your immune system to then take those plasma cells out. There are a number of studies going on of all different combinations. This is a little bit of alphabet soup, but the one that I'm going to be talking about is called the Griffin study. And this was a randomized phase 3 trial. So this is the furthest along in terms of FDA approval of adding daratumumab, which many of you have had, but at the time of relapse, this is instead adding it to the combination of RVD in the upfront setting. And this is compared to standard RVD. And so this study is just reporting out now. It's early data. It's still early for this. But what we see is that the addition of daratumumab to RVD improves the response rates, so how well patients' myeloma responds, and increases the time to progression, so that the length of, we don't have that mature data yet, so but we just have the response rates. And then the addition of daratumumab to Revlimid maintenance. So Revlimid maintenance is our standard of care. It also shows increase in response rates and increasing the depth of response when compared to Revlimid alone. We're still waiting for the progression-free survival to read out, so it's too early to call that. But I think that this data is encouraging enough that the addition of daratumumab or other similar like isatuximab, which also targets CD38, to the upfront triplet may now be our new standard of care for some patients with newly diagnosed myeloma. We are very excited about this at MGH, and we currently have 2 clinical trials that are ongoing. One of them is the combination of lenalidomide Revlimid with ixazomib, which is like an oral proteasome inhibitor like Velcade, with daratumumab and dexamethasone. Everybody is receiving this. This is for transplant ineligible patients, and then the maintenance phase is randomized, looking at 1 drug versus 3 drugs. This is an important question because, again, it gets back to the is less more, but this is a really nice quad in the upfront setting that we're leading. Another ongoing study, and this is in the transplant eligible population, is adding isatuximab, so another CD38 monoclonal antibody to the combination of carfilzomib, Revlimid, and dexamethasone, with the option to either have a transplant upfront versus deferring it, with all patients getting collected. And again, we're looking at the question of the right maintenance drugs for ongoing disease control. So this is really exciting news for us. We're actively studying it still, but maybe our next improvement that we see in the upfront setting. And now I'm going to talk about the care of myeloma as we move forward in the future, and using minimal residual disease may be a tool to help us better treat you. So what is minimal residual disease? It's the presence of a small amount of myeloma cells in the bone marrow following the achievement of a complete response after treatment. It can detect cells at a much finer level than just looking at a bone marrow biopsy under the microscope. Very often we talk about myeloma as an iceberg. What you can see above the water is what we can measure in your blood on your SPEP when we talk about your blood proteins to you. And we try and go deeper and deeper with each line of with each therapy to get you into a partial remission versus a very good versus a complete. But we know that there's even a lower level below that, and that's where we get into minimal residual disease. And so it's a different tool. It's done by next generation sequencing. It's something that we do primarily in research studies to help us understand our depth of response, but it's something in a forward-thinking way that we might be able to use as part of our treatment strategy. And I'm going to highlight two ways in which this may influence treatment of newly diagnosed patients in the future. So when patients receive their combination therapy, someone, if they look like they're in a CR and we send testing for MRD, if they're MRD negative, we could then store those cells and move patients on to maintenance rather than having them go through high dose chemotherapy involved in transplant. Whereas if someone still had evidence of residual disease, that would be our indication to go through transplant. And again, this is both ways you're getting to that deepest depth of response, but it's guiding the intensity of therapy, really looking to optimize patient quality of life and treatment intensity. This is another illustration of how we might be able to use MRD in the upfront setting going forward. It's called the MASTER trial. This is a 4-drug combination, again, of daratumumab with carfilzomib, Revlimid, and dexamethasone. And the way that this study is using MRD is to actually take patients off of treatment and observe them and follow MRD levels, because even Revlimid has side effects, and those side effects persist over time, and some of them even get worse over time. And so if we can identify the patients who don't need intensive treatment, that may be a way that we make myeloma therapy better. So in this study, they did 4 cycles of Dara KRD, checked for MRD, did a stem cell transplant, checked again. And for those patients, and we can see on the next slide, there was 37% of those patients were able to come off treatment. For those who weren't MRD negative, they continued on to receive 4 more cycles. And you can see another percent of patients was able to come off treatment and be observed. And this continued successively. And the take-home message here is that this is a tool that may help people receive the right amount of therapy, not too much, not too little, to achieve optimal myeloma responses. So what are our take-home messages? Quadruplets with a monoclonal antibody, an immunomodulatory drug, a proteasome inhibitor, and steroid may be a new standard of care in both transplant eligible and ineligible patients. The study that I presented was for transplant patients. The studies for transplant ineligible patients are ongoing and should be reading out shortly. RVD Light and Dara-RD reduce toxicity and are good efficacy in transplant ineligible patients while we await the final outcomes. And again, we have our own study that's a nationwide study of daratumumab in combination with Revlimid, Ninlaro, and dexamethasone. Sometimes we use doublets. That's very reasonable, particularly in people who are frail or have other medical problems. The bottom line, though, is that your treatment plan has to be individualized, and we have to balance disease control with all of the other factors of your life and medical care to make the best decisions for you. Myeloma is a dynamic and rapidly evolving field. We feel so privileged to be here on the forefront of it here in Boston and to be really doing our best work to try and create the best treatments for you. One other important component is just supportive care. For all the medicines we give, making sure that we avoid other problems is very important. Taking care to put patients on shingle prophylaxis, on blood clot prophylaxis, to protect your bones with zoledronic acid or denosumab. Use of vaccines, as Noopur discussed, is critical, and other supportive care. I do want to highlight that we do have social work, palliative care, physical therapy, and rehabilitative medicine here, all within our cancer center to help support you through every phase, not just the newly diagnosed phase of your treatment. I want to again thank everybody for being a part of the MGH family. And I want to introduce my good friend and colleague, Dr. Yi, who will be now moving into really the exciting discussions of the relapsed and refractory and all of the innovation and new drugs that are coming our way. And so with that, I'm going to stop and let him go forward. Thank you.
Thank you, Betsy. And let me Just give me a moment to get my presentation started. Okay, so well, again, thank you, Betsy, for the introduction. And I also want to thank everyone who's able to spend a morning with us to talk about multiple myeloma and Waldenstrom's macroglobulinemia. It's a privilege to be able to take this morning to share some of the exciting new developments in our field and to kind of have an opportunity to talk about this. It's kind of different than when you see us in clinic. This gives us the chance to kind of provide a little bit more perspective on where things are at with treatment and where we think things are going. And I also wanted to acknowledge a lot of, it's great to see a lot of familiar faces among the attendees. So thank you again for joining us. So today I'm tasked with talking about relapsed disease, and this mainly applies for when our goal for the initial therapy is to have the disease stay in control for as long as possible while maintaining and improving your quality of life. However, over time, for some patients, the disease does appear again and become more active. And when we think about treating relapsed disease, some of the same considerations that Betsy talked about in newly diagnosed patients also applies when we talk about how we approach relapsed disease. So we think about patient-specific factors in terms of the patient's physical status and other comorbidities. What treatments has a patient received before, as well as patient preferences in terms of convenience, oral medication versus infusional medication. So those are patient-specific factors. And we also talk about specific factors, such as what's the nature of the relapse. So for many patients, if the disease does become more active, it's mainly just based on the blood test. The patient overall feels fine. And this is just on a routine follow-up blood test. You see changes in, say, the monoclonal protein or the light chain. And this is in contrast to a clinical relapse where the disease has more to it in terms of symptoms that can be associated with the relapse, such as a new bone lesion or worsening blood counts. We think about, is this relapse occurring earlier on the disease course, or is it later on when a patient's been on treatment for many years? And we also think about the tempo, like, is this again like a gradual, or is it more of an aggressive relapse? And then, as Noopur and Betsy talked about earlier, we are also starting to think more about the biology and the molecular underpinnings of the disease in terms of trying to figure out if there's something that's actionable in terms of how we think about the disease, in terms of the treatment. So, if there's a presence of a TLM14 translocation or presence of potentially actionable mutations. So all these factors go into how we think about the specifics of the treatment. For some patients who have a gradual relapse, you can do more of a less intensive treatment. But for other patients where the relapse is more active and patients have symptoms, we think about more intensive treatment that's more involved. And throughout this whole journey, we always think about clinical trials were applicable in terms of trying to better understand how we can move the ball forward in terms of coming up with better treatments. So this is a figure that Betsy showed earlier, and again, I just wanted to emphasize that there are so many new that we're lucky in the multiple myeloma field that we have all these new treatments that are emerging. And for example, we had 3 drugs that were just approved in the past 2 years, and that there are a couple new treatments that are on the horizon and potentially could be approved this year. And I think we all feel fortunate to be able to practice in a setting with the resources and the team and the infrastructure to be able to offer these approved drugs, as well as some of these newer treatments that are in clinical trials, in which I'll talk about in a moment. So this figure here, I know it's a little bit busy, but this sort of provides a framework for where we can think about how the current treatments are, and then the targets, and where the newer drugs and newer treatments fit in. So for example, we have drugs that are sort of like next generation versions of lenalidomide and pomalidomide, drugs like iberdomide and CC-92480, which are in clinical trials. We have like melflufen, which is a more tumor-specific version of older drugs like melphalan. We talked about venetoclax, which targets T1114. And then I think I'm going to spend most of the discussion talking about drugs that target BCMA. So we already have a drug that's FDA approved, which targets BCMA, but drugs that are on the horizon include T-cell engagers and CAR T-cell therapy. So these are treatments which Noopur, kind of alluded to before in terms of using your immune system more specifically to target multiple myeloma. So BCMA is a protein that's on the surface of myeloma cells, sort of analogous to how CD38, which is the target of daratumumab, and isatuximab is on the surface of myeloma cells. And this is a protein that is more commonly found on plasma cells and specifically multiple myeloma cells. And there's several ways of targeting BCMA. So belantamab mafodotin, also known as Blenrep, is a drug that was just approved back in August. And this is an antibody that targets BCMA, but connected to this antibody is this warhead. In this case, it's mafodotin. So this, using Blenrep, this drug kind of brings this drug directly into myeloma cells. And now we are also exploring newer therapies such as the bispecific antibodies. So a bispecific antibody is an antibody that has like a dual role where it binds to both BCMA, but also binds to CD38, which is on a specific kind of white blood cell called the T cell. And then there are CAR T cells, which is reprogramming these T cells to specifically attack BCMA. And I've highlighted here, there are a variety of programs that are that in the bispecific antibody space and in the CAR T cell space. So what are CAR T cells? So this is something we talk a lot about, specifically in patients who have been through several lines of treatment. And CAR T cell therapy has been around for several years now, and it was first established in childhood leukemia going back to 2012, and it was actually approved in 2017, and now it's approved in lymphoma. And the hope is that we can take the same platform and apply it to multiple myeloma. So this is sort of a schematic in terms of how CAR T cell therapy works. And in CAR T cell therapy, patients have white blood cells collected, sort of similar in the fashion where if you're having stem cells collected for an anticipation for autologous stem cell transplant, your white blood cells are collected, and then they get sent off to a laboratory or a company where they are reprogrammed so that these white blood cells, these T lymphocytes, specifically attack BCMA, which is on the surface of multiple myeloma cells. And then patients receive lymphodepleting chemotherapy in order to prepare for the receipt of these CAR T cells, and then these are infused. So this is, again, to be more specific, this is sort of an example of how this works, for example, with this CAR T cell therapy, ide-cel. And so right now, for many of the clinical trials, patients who are eligible for these CAR T cell therapies generally have been through multiple lines of therapy. And for these clinical trials, they also require patients to have adequate hematologic function and kidney function. So again, the cells are collected and then they're manufactured. And that takes about a month. And while the cells are being manufactured, in some patients, we give them some additional treatment to kind of keep the disease stable while the cells are being manufactured. Now, prior to receipt of the CAR T cells, patients receive lymphodepleting chemotherapy. So this allows the CAR T cells, when they're infused, to expand. And then generally, for many of the trials, there's about a 2-week hospitalization to monitor, mainly for side effects. The one thing I wanted to emphasize as sort of a unique distinguishing feature about CAR T cell therapy is in the way that current CAR T cell therapies are being used, is that it's sort of like a one and done type treatment where patients receive one CAR T cell infusion and then they're observed from that point forward. There's no, a lot of the treatments we have, involve repeated visits for infusions or continuous therapy on an oral medication. And one distinguishing feature for CAR T cell therapy at this time is the idea that we can just do one therapy and then observe. And for many patients, that can be a huge improvement in quality of life. So I just wanted to illustrate some of the early data with CAR T cell therapy. And this is a trial that was led by Noopur. And in this trial, these are patients who've received many lines of therapy and have received almost all of the usual approved therapies in multiple myeloma. And you can see for these patients who've been through a lot of treatment that you have this kind of almost an unprecedented response rate that was 90%. And you can see here that in 2 weeks, if you repeat a bone marrow biopsy, you can see that the bone marrow is cleared of myeloma cells. And if you do PET CT scans, you can see that the disease can't be seen anymore. So again, this sort of illustrates the power of harnessing and reprogramming your immune system to attack myeloma cells. Now, with CAR T-cell therapy, there are some side effects to think about when you use this type of therapy, or kind of when you're using your immune system in this fashion. So this falls into two classes. One class is cytokine release syndrome, and this refers to a set of side effects that happen when their immune systems are activated. And it's sort of, I kind of analogize, there's an analogy to as if you have like dealing with a cold or the flu, where patients can have symptoms like fever and just having muscle aches. Now, in some cases, the side effects can be more pronounced, where you can have low blood pressure and effects in organ function. But fortunately, as we've had more experience using CAR T cells, we figured out better ways to kind of manage and minimize the likelihood of these from happening using therapies like tocilizumab. The other type of side effects include effects on your sort of neurotoxicity. And this relates to, so for some patients, it's sort of having kind of a chemo fog or chemo brain, but in some patients, occasionally the side effects can be more severe. But fortunately, with time, as we've had better ways and more experience using CAR T cells, again, the likelihood of having these more severe side effects is less likely. Now, this slide here just sort of illustrates kind of the range of CAR T cell therapies that are under active investigation. And right now, it's too early to know, which one is the best one. But I think on this slide here, I think the ones that are furthest along in clinical development include, ide-cel as well as cilta-cel. These are studies we both participated in. And I also wanted to mention that another way of thinking about CAR T cells is using the T cells from a healthy donor instead. Because right now, these CAR T cells are being manufactured from the patient. But it's possible that in the future, we may be able to have these T cells being manufactured from a healthy donor. So in terms of the future, I think some of the key messages is that some of the highest responses are seen with using this type of therapy. And hopefully, we might have this approved maybe even as early as this year. Now, one thing to appreciate is that, we're still working on optimizing this in terms of, the hope was that this could be curative. Like, for example, in lymphoma, some patients with lymphoma are cured using CAR T cell therapy. But in myeloma, we're still working on trying to figure out how to best optimize this. And along the way, we're also trying to figure out that perhaps if we use CAR T cell therapy earlier in disease, like say in the beginning, or maybe after in the first or second relapse, perhaps you can get better responses as the lymphocytes where these CAR T cells are made might be in better condition, and the disease might be easier to treat earlier in the disease course. Now, shifting gears a little bit would be to be talking about bispecific antibodies. Again, the common theme here is that we're using your body's immune system to attack the myeloma cells. And so again, in bispecific antibodies, there's a range of platforms that are under active investigation, and we're fortunate to be able to be actively involved in some of the clinical trials using bispecific antibodies. And similar to the CAR T cells, there's a risk of having, because again, we're using white blood cells, and there's a risk of having the cytokine release syndrome and neurotoxicity. And as a result, there's more monitoring that's involved when we use these types of therapies. And again, this slide here is just to illustrate that there are multiple trials which are investigating bispecific antibodies. And we're lucky to be, and fortunate to be participating in several of these trials. And this slide here illustrates that, again, that we're using these bispecific antibodies, that you have these really exceptionally high response rates in patients who, again, have been through multiple lines of therapy. So the hope is that in the future, targeting BCMA may emerge as a new standard. Now, in terms of which of these therapies will come out ahead, I think, again, it's to be determined, since we're still early on in investigating these therapies. And I think each of these will have a specific role to play. So each of these therapies has advantages and considerations to think about. So for example, CAR T cells, I think the great thing about CAR T cells is the depth of response and the fact that it's one and done. But again, the limitations, you have to wait for these T cells to be manufactured, and that these, because of what's involved in the monitoring and logistics, it's generally being done at major medical centers. So we're fortunate to be positioned to be involved in the trials with CAR T cells. And the bispecific antibodies have efficacy that's approaching CAR T cells. And one of the advantages of this is that there's no wait time to administer. You can do bispecific antibody, and then you can move forward rather quickly. However, with the bispecific antibodies, there's still side effects to manage, such as cytokine release syndrome. But again, I think as we get more experience with this, these side effects will be less and less of an issue to consider. And then finally, we have antibody drug conjugates that were involved also in clinical trials with this as well. We already have an antibody drug conjugate that is approved, which is Blenrep. So that has the advantage of being able to be given, without, being on a practical level that's more easily accessible, including for patients in the community who may not have the opportunity to travel into a major medical center. However, one consideration with this drug is that it can cause ocular side effects. But again, as with all therapies, I think the hope is that with more time and more experience, these side effects can be easier to manage. But I think the overall theme here is that with more treatment options, again, the hope is that we have better outcomes in multiple myeloma. And again, so some of these treatment options we're talking about can also eventually reach a stage where we can bring them on for newly diagnosed patients as well. So again, I want to thank you for your time and for listening and for giving us the opportunity to share some of the excitement and some of that we have for what we can bring for our patients, and also to acknowledge all the infrastructure, the support, and the teamwork that goes into being able to do these clinical trials. So I think that really can't be understated in terms of how many people are involved with being able to do this for our patients. So now it gives me great pleasure to introduce to you Dr. Andrew Branagan, who focuses on multiple myeloma, but he also has a special interest in Waldenstrom's macroglobulinemia, another plasma cell disorder. So he's going to spend the time to talk about some of the newer developments in Waldenstrom's macroglobulinemia. So Andy, the floor is yours. Thank you.
Thank you so much. Really appreciate that, Andrew, and great job with the talk and all the other panelists. It's really exciting to be here this morning, and I'm very impressed by all the folks who have joined. It's really amazing, and the chats that are coming in. Great questions so far. So as Andrew mentioned, I'm going to talk a little bit about Waldenstrom's macroglobulinemia. And that's a real treat, I think, because this is often neglected. It's a rare disease, and it's really great to give it a little limelight today. And then I also want to talk a little bit about infections in patients with Waldenstrom's myeloma and other plasma cell disorders, because I think that's another unmet need. So here's the specific objectives I wanted to cover today. Talk about the clinical features of Waldenstrom's, discuss some of the current management and research efforts for patients with Waldenstrom's, and then again end with some a little bit about why there's more infections in patients with plasma cell disorders and some research efforts we have ongoing to try to overcome those. So this on the right here is a picture of Jan Waldenstrom, and in the 40s he described this disease, Waldenstrom macroglobulinemia. At the time, wasn't known exactly what it was, but he knew there was something big in the blood, and that's what the word macroglobulinemia means, something big in the blood, and that thing in the blood was IgM molecule. And so this is an interesting disease because it's both a plasma cell disorder and it's also a non-Hodgkin's lymphoma. And this is characterized by a bone marrow involvement of different types of white cells. So it has actually lymphocytes and plasma cells, and it has a monoclonal IgM. And that's different from myeloma, because in myeloma, you often have an IgG or an IgA. And I'll explain why that makes this disease a little more unique. It is a rare disease, about 3 cases per million, and the median age is somewhere in the late 60s in general. It's more common in men than women. And you can see here the many different manifestations of Waldenstrom's, and I think that really makes this a very interesting and challenging disease to study and care for. You can see in the middle, this is an example of bone marrow involvement, and just like myeloma, these abnormal plasma cells and lymphocytes can crowd out the healthy cells, and you can see decreases in cell counts, such as red blood cell counts or anemia. Because the IgM is a big molecule, you can actually see thick blood or hyperviscosity, and I'll say more about that in a few moments. Also, IgM is unique that it can cause a lot of autoimmune complications, such as cold agglutinins or cryoglobulinemia. And also the IgM is more likely to cause neuropathy. And that can be a major issue for patients with Waldenstrom's. Just like myeloma, it can be complicated by amyloidosis. And that's an abnormal deposition of pieces of the antibody in tissues throughout the body. There's a very common prevalence of iron deficiency anemia in Waldenstrom's because of a disruption in this regulating molecule hepcidin. And then just like lymphomas, you can actually get enlarged lymph nodes through the body and also enlargement of lymph organs. And again, everybody's different, and not every 2 people are even the same with Waldenstrom's. Waldenstrom's can actually get into the brain or central nervous system, and that's then known as Bing-Neal syndrome. And so what are some signs, many of these complications I mentioned, and many of those same complications are reasons to be treated, because not everybody with Waldenstrom's needs to be treated. Some people can actually be asymptomatic their whole life. Most commonly, it's anemia, very similar to myeloma, and that is a reason to be treated. But there are several reasons for the anemia. So in general, a thorough workup is indicated. You can get hyperviscosity, again, the thick blood, and the neurological symptoms, they can be for different reasons. So generally, there's several studies that are needed to know what's causing the neuropathy and how can that best be treated. And so you can see on this picture here, here's a picture of IgM. It's not to scale. It's actually a lot bigger than the other antibodies here. Most antibodies in our blood are IgG, which look like this. IgA looks like this. IgM has lots of binding sites. It's very big and can thicken the blood. And for some patients, this happens with an IgM over 5,000, but it can happen at varying levels. It can cause a lot of serious neurologic complications. So this is a really important thing to monitor with Waldenstrom's. And so here's just a picture of the back of somebody's eye who had hyperviscosity. And to the right, you can see these are very engorged giant veins. And if you look closely, they actually look like sausages, that when sausages come on a rope, they're bulging so much. That's called sausaging. And then you see these red spots, and these are called the flame hemorrhages. And you'll notice that it tends to happen more toward the outside of the eye. And it's important to have a good ophthalmologic exam if this is ever suspected. And the ophthalmologist actually presses down on the eye to see the very edges of the eye. And so a discovery about 10 years ago was this mutation called MYD88 L265P. And you can see here in the cartoon, MYD88 sits right below a toll-like receptor. These are major receptors on B cells, and they're very important for everyday function of B cells. When we get exposed to a new virus or bacteria, pieces of that pathogen bind and it activates that B cell. And so it knows to make antibodies against it to fight that infection. But in the case of Waldenstrom's, this protein makes this receptor always on and always active. And those signals get propagated. And so this is a growth and survival signal that these cells actually don't die and they keep dividing. And this is in most Waldenstrom's patients by far. Over 95% of patients have this mutation. And I'll talk a little bit about later, but because of this, this mutation, right downstream is a molecule called BTK, and there are established drugs that can block this receptor and overcome this activated pathway. The second most common mutation in Waldenstrom's is known as CXCR4, and this is just more recently being recognized. And what CXCR4 generally does is it's an important receptor in the bone marrow where cells get adhered to the bone marrow and not released into the bloodstream. In the case of Waldenstrom's, it's mutated, and it gives lots of extra signals to the Waldenstrom cell, including drug resistance, and it also signals increased production of IgM. And patients with this mutation tend to have higher IgM values and other complications. And so this is a list of all the, or many of the standard treatments for Waldenstrom's. And the top highlighted in the red bar is rituximab. This is a monoclonal antibody, and it targets a protein on the Waldenstrom cells. This is by far the most common treatment used for Waldenstrom's. And you can see here overall response rates, depending on how many doses you get, range from 1/4 of patients to half of patients. But when something is added to that Rituxan, you can see here really high overall response rates. And what can be added can be chemotherapy, or it can be proteasome inhibitors, for instance, some of the drugs we heard about from Andrew and Betsy. And so we have excellent overall response rates. These translate into long times before patients need another treatment. And what you might notice, though, is there's really not a lot of complete responses. So those are rare. So similar to other indolent lymphomas, where people live a long time and often don't need treatment, these cells are slowly dividing, and it's very hard to get a complete response. Now we have a drug called BTK inhibitors, or a class, and there's the drug that was most studied and furthest along is known as ibrutinib. And you can see here overall response rates very similar to these Rituxan combinations, and these also translate into long-term periods before you progress and need another treatment. And one thing I want to point out, so this is from this first study done with ibrutinib and Waldenstrom's. These are people who were previously treated, and this was just updated this past year in 2020. And in 2020, there was a 5-year experience. So this is just a snapshot at 5 years. And you can see here, patients who had the MYD88 mutation alone did extremely well. And most of them were still taking the drug and not progressing. If they had the second CXCR4 mutation, more patients had progressed by that time in 5 years. And then you can see here, just to kind of reiterate, the few patients who don't have the MYD88 mutation, that's called MYD88 wild type, it really does not work, this class of drug, and they actually progressed very early on. And so where are we going with the future? So this ibrutinib drug is excellent, but some people do develop resistance. There are certain side effects associated with it. So we have other BTK inhibitors with different side effect profiles, very, very promising. And there's even more. There's some that can overcome resistance if somebody becomes resistant to a BTK inhibitor. So these are currently being studied. Venetoclax, another drug that we heard Andrew discuss for myeloma, is very promising for Waldenstrom's. It's probably going to come into the guidelines later this year, where a trial showed excellent responses. And what this does is it's also a pill, and it overcomes a protein that's overexpressed on Waldenstrom cells, BCL2. And another thing for the future is CXCR4 inhibitors, and I'll show you in a minute some examples of these. And so, you know, the question is, can we overcome this mutation and the adverse effects it has with Waldenstrom's patients having their treatments? So I'm going to just show you a couple trials we have ongoing. This is a trial combining ibrutinib and venetoclax. This is for patients with Waldenstrom's. So the way ibrutinib works is it's a pill, and you have to take it indefinitely because you're overcoming a mutation. The venetoclax is a pill that I mentioned you also take orally. The venetoclax is actually very good at eradicating disease from the bone marrow. And so what it seems like is by combining these drugs, we're going to get deeper responses than have ever been seen. and perhaps we can actually stop having to take this medication indefinitely. And so the trial will look at stopping therapy at 2 years and see if that's even better than somebody just taking ibrutinib alone indefinitely. And now I want to show you some of the efforts to overcome that CXCR4 mutation. This is a trial that combined ibrutinib with ulacuplimab. And if you were to take ibrutinib alone and you have the CXCR4 mutation, we know that it takes over 6 months for that drug to work. By adding this CXCR4 inhibitor, we actually saw patients' IgMs dropping very rapidly, even after just 1 and 2 months, as opposed to over 6 months. So this was very promising. It was an IV drug. Now we have actually an oral drug called mavorixafor. It does the same thing. It blocks the CXCR4 mutation. So we're very excited about this trial. This is ongoing. It's being combined with ibrutinib the same way the IV drug has been. And that's everything I wanted to say about Waldenstrom's. And with the rest of my time, I wanted to talk a little bit more about infections. I want to point out that you can think of plasma cell disorders actually as cancers of the immune system. And in fact, infections are a leading cause of illness and even death for patients with plasma cell disorders. I think this is a very important unmet need. Not enough people are doing research in this area, in my opinion. There is, in fact, a 10 times increased risk of having viral infections if you have a plasma cell disorder, 7 times increased risk of bacterial infections. And despite getting routine vaccinations, often the immune responses are blunted, and sometimes there's just a partial benefit to immunizations. So some of my research has been to try to figure out why and how can we overcome this issue. And so I want to highlight a recent trial, and this is looking at influenza vaccination, and it's called the Shivering trial. And you can see here that the control arm is just how all of you get your vaccine each year. It's based on age. You get a single vaccine each, in the beginning of the flu season. If you're over the age of 65, you get a high dose vaccine. Under the age of 65, a regular strength vaccine, and that's it. In this trial, we randomized patients to receive that standard of care, or they got 2 high dose flu vaccines. And this was regardless of age, everybody got the high dose. And so you got 1 high dose, and then 30 days later, a second high dose. And patients were followed, and there were a lot of other endpoints to understand immune responses. With the time I have here, I just want to highlight this very important one, and that's that after a second high dose vaccine, there was an improvement in those patients over those who just had the single vaccine. This was a significant improvement. More patients had protective antibodies against the flu. And then one of the most surprising findings was we looked at protection at the end of the flu season. And what we didn't appreciate is how quickly patients with myeloma and Waldenstrom's lose their protection, even if they get it. And by having that second vaccine, this was mitigated. And at the end of the flu season, twice as many patients had protection against the flu. And so with this in mind, we've been starting to give 2 doses of flu vaccine. We do expect this will get into the guidelines for multiple myeloma within the next year. And where are we going to go with this? Obviously, we need to examine COVID-19. Noopur did an excellent job overviewing the devastating effects that COVID had on all of us, and especially on all of you as patients. And we have a trial that's been submitted. It's going to be opening very soon. This will look at over 150 patients and really look at comprehensive immune responses to COVID-19 vaccines. It's not giving any specific vaccine. It just will examine your response to a vaccine that you're going to have anyway. And we'll see the differences between vaccines. We'll see how many patients can get an antibody response, what type of antibody response, and also white blood cell responses against COVID-19. So a very comprehensive analysis. We hope that this will inform future studies on how we can actually improve protection to this and other infections. And I do want to point out there's no pharmaceutical funding, unlike all the drug trials we do to find new drugs. This one relies primarily on past and future philanthropic support. And so I really want to thank all of you, especially past donors. I want to thank everybody's interest. If you want to join this trial, please let us know. If you want to support the trial, please let us know. Thanks for everything you do. And I thank my team. I think it's one of the best places to work in the world. And I'm going to invite all their beautiful faces to come back, and we're going to have a panel discussion to go through your questions. Thank you very much.
Fantastic. Thank you so much, Andy. That was a really great overview on Waldenstrom's and infection, which is sort of underappreciated. And thank you, Betsy, Andrew. You all did a tremendous job walking us all through a lot of data. I think the bottom line here is, despite the pandemic, it's been an exciting time for plasma cell disorders. We've continued to make tremendous amounts of progress in the laboratory as well as with clinical trial development. And I do think we're on the verge of having the first CAR T-cell product approved, hopefully in March of this year. It's sitting with the FDA as we speak and really providing you access to these cutting-edge therapies is what we do. The chat function has been very, very busy, so we appreciate your involvement. And I'm going to start looking through some of those questions and sort of pose it to folks who sort of addressed that. So Betsy, I'm going to start off with you. There was a question on transplant. And the question really was, are there specific criteria for transplant eligible versus ineligible, and what would those be?
Sure. So again, this is definitely nuanced, but the historic criteria were age determined. So anybody under the age of 65 is eligible for a transplant. Over the age of 65 was the historic definition. There have subsequently been studies that have shown people up to the age of 75 can tolerate transplants. But again, the issue also becomes patient preference, of course, and then other factors in terms of how are you doing? What is it's a large dose of chemotherapy. Will you tolerate that? Would your kidneys tolerate that? So there are some objective criteria, but then there's a lot of soft criteria, and it's usually a discussion.
Thank you. And, age, absolutely, Betsy, as you pointed out, but in the United States, we don't use age as much and even the Europeans have actually moved that. And really, as Betsy has pointed out, it's to do with your disease status and your associated other medical problems. And it is a choice. So having that discussion, as Betsy has pointed out, is really, really critical. So there's a couple of lots of questions actually, Andrew, around, I'm going to start out with sort of the diagnostic pieces. There were a couple of questions on what do you follow in a patient with myeloma in terms of laboratory data? And then there was a specific question addressed to Andrew E. And that was a question of what free light or what light chain number would you be worried about in terms of starting treatment? And then I'm just adding one more question to that, because there was another person who asked talk a little bit about the free light chain ratio, if you will.
Right. Okay. Thanks, Noopur. I think we could spend a whole separate webinar talking about how we measure myeloma. But so for myeloma, there are different ways of measuring the disease, and that sort of relates to the fact that myeloma, not all myeloma is the same. So some myeloma just makes a monoclonal protein, which is just seen on the SPEP. Some myeloma patients, the disease is mainly measured as the light chain. And then some patients have a combination of both a monoclonal protein and the light chain. So I think one of the questions relates to, so about 20% of patients will just have light chain only disease. And so generally speaking, when you see us, we generally measure all those parameters at each visit. It's like once a month, every 2 months. It really depends on how frequently you see us. And in terms of what constitutes, a relapse, A lot depends on, it can be somewhat subjective in terms of, how we think about because subjective in the sense that it can be really very patient specific. So if the light chain is gradually rising, like say 5-10 milligrams per liter, month by month, that might be one approach, versus if it increases by 100 or 200 or 5, or if it doubles, like goes from 100 to 200, that feels different than if it's just a very gradual. As a side note, for any listener who doesn't seen here at MGH or in a partner's facility, the units are also different too. So when you see us, it's in milligrams per liter, but in other institutions, it can be off by a factor of 10, where it's in milligrams per deciliter. So that's just one nuance to appreciate.
Yeah, no, thank you for that. And I just want to underscore a really important fact here is everybody's myeloma is different. So one number for one patient can be very different from another patient. So a light chain of 100 for patient X may be something we would want to treat, whereas somebody with a light chain of 2000, we may be telling you that we're going to be watching you. So it's honestly the pace of the disease and understanding the disease on a whole, but the light chain ratio is something we follow routinely on all our patients with multiple myeloma. So Andrew, thank you for that. It's the SPEP and the serum free light chain, which are followed in general for your myeloma, and that's something we kind of do every time you come visit with us or every time you see your myeloma specialist anywhere. There's a lot of questions around BCMA CARs and BiTEs. We're just going to hold on to those for a little bit, and we're going to address a couple of questions on MRD. And last, I think, Andy, we'll go to vaccinations because there's a whole host of questions on vaccinations. And I do want to get to those because I do think that's on everybody's mind right now. So before we go there, Betsy, I'll pivot to MRD. You did a really awesome job explaining the importance of MRD. I'll start out by asking you, should you be doing MRD testing routinely in our patients? And number two is, are we really using treatments to drive towards MRD, or should that be the goal in the future? Especially with maintenance, do we want to control disease or do we want to get to MRD negativity?
So I think that these are really important questions, and I think that we're really on the cusp of starting to answer these better. One thing I didn't say when I was talking about this is to do MRD, it does require a bone marrow biopsy. So it is invasive. There are blood tests that'll do MRD, but at this point, that test is not as sensitive as is the bone marrow. So the question, and I think what the master trial highlights is, if you do the test, is it going to change your management? Our goal is always to get to the lowest disease state. However, we have a lot of drugs, but they are still a finite amount. And so there is a balance of getting the maximum response that you can out of a certain regimen. We know not everybody gets to a CR and not everybody gets to MRD negativity. And so when you're using a specific regimen, we want to get you to the lowest disease state. That may be a function of how much you receive over time, because we know that depth of response increases over time. But even you could be on something, for 2 years and not get to that state of MRD negativity. The question then becomes, well, do you move on? I think what you're asking is, do you move on to something different with that goal versus recognizing you've gotten to a very good disease control, sticking with it? And right now, if you have something that's working, we typically advocate for staying with it, with the goal of, perfection being the enemy of good. However, I think that MRD is a very important tool. And as I highlighted, it may be able to help us decide who does and does not need transplant at a given time. And if there's a way to reduce therapy, like you showed with the maintenance, and thereby reduce toxicity, that's another way to use it. But switching therapy at this point to go after that is not our standard of care. And I'd welcome my colleagues to jump in and comment on their thoughts as well.
Yeah, I think you're absolutely right, Betsy. We are not using MRD in routine practice just as yet, and I think we should wait on the clinical trial. The past master data, which Betsy showed us, is very intriguing, and our hope is that we can use this test to tailor therapy in the future. We're not quite there just as yet, so thank you for that. Andrew, I'm going to get to you with CAR T cells. So a couple of questions around CAR T cells and bites. One is when does CRS usually happen? And just the second part is if you fail a CAR T cell, can you go on to a bite? And vice versa? And what about newer targets for the bites like the GPCR5D protein as well as the FCHR, where we have bites as well as CAR T cells? Can you do that after you failed a BCMA bite or a CAR? Andrew, you're on mute.
Sorry, that was a little JV, so to speak, on my part. A little embarrassing. Okay, so
this sounds like our Wednesday morning meeting, guys.
A rare moment where Andrew creates a technical difficulty.
So okay, thanks. I think the questions there are sort of the core questions that everyone in the field is asking. So let me start off with the CRS. So most of the CRS happens right in the beginning. So most of the CRS happens like within the first day or two, and if CRS is to happen, it's really in the first week. And as a result, that's why the hospitalization is sort of baked into a lot of the clinical trials, is to really to monitor for CRS and potential for neurotoxicity. And the same issue with CRS with the CAR T cell therapy also applies to the bispecifics as well, because some of the bispecifics have more at risk for CRS than others. But again, that's being optimized as we figure out different ways. Maybe subcutaneous is less than IV. So then the next question is, what happens if the CAR T does not work as well as you would like? And that's sort of a question that that's sort of an intense area of active interest. So there are a couple branch points. One, if the initial BCMA therapy doesn't work, now there are an increasing number of trials with CAR T that are looking at patients who've had prior BCMA therapy, including prior CAR T therapy. So if that BCMA therapy for the CAR T doesn't work, other CAR T trials might be potentially an option, or other bispecific antibodies may also be an option for targeting patients where the initial BCMA CAR T did not work. And then Noopur mentioned a couple of other targets, GPRC5D and then FCRH or FCRH5. So there are a couple of new targets, which is really exciting. I think, that created a lot of buzz because at this recent ASH meeting in December was really the first time we started to hear data for it being presented. And the key thing with those targets is that these are targets that are sort of on the cell surface. And these trials looked at patients who've had prior BCMA therapy, and in those patients were able to see responses. So we have, bispecifics that are targeting GPRC5D. There's also some emerging CAR Ts that are targeting those as well as other targets that, we're actively involved in at MGH. So that's really potentially exciting. And then also potentially, there's also the off-the-shelf belantamab mafodotin that you could also use if the CAR T doesn't work, as well as other trials outside of BCMA as well. Sorry.
And one other comment about not just rotating BCMA products, but for some patients after getting CAR T or other BCMA products, they respond to treatments that they hadn't in the past. So maybe there's some sort of changes to the immune system we're starting to understand. So there's still some hope in that regard.
No, absolutely. That, Andy, is a really important point. We've seen post-CAR T cells, even if the disease comes back, your response has changed, and that we do believe is immune related. I just want to remind everybody that this is a recorded session, so you can actually access it, as Devin has pointed out in the chat section. It's on our website, so you will be able to listen to it later on. Last 5 minutes I want to spend on vaccination, Andy. Lots and lots of good questions on vaccination. I'll start out with a couple of those. One is, do we know if myeloma and Waldenstrom's patients actually mount an antibody response to the COVID vaccine? Do you want to get at that? Or let me just ask you a couple of others. Is there a choice between the different vaccines? Is it safe to get the vaccine? Because I do see in the chat that there still seems to be some vaccine hesitancy. Do you want to address those?
Yeah, we don't really know if one's better than the other. Again, that's one of the reasons we want to look at all vaccines in our study. This is a very common area research, and other people are starting to look at this around the world, actually. And some people have started to look at antibodies against the proteins on COVID that you can detect after a vaccine. And there certainly are myeloma patients that can make those antibodies. And we also know that there's myeloma patients that can make antibodies after actually getting infected with COVID. Interestingly, natural infections are some of the best ways to get immunity. And so it may be similar to the flu, where if you actually got COVID, you have a more powerful immune response than a vaccine. And so we really need to understand how close can we get with the vaccines. Is one vaccine better than another? And that's part of what we're going to study with this and other trials. And then you had a comment about allergic reactions. So far for the available vaccines, there is a risk of very few people have had anaphylaxis, and that's why generally you're watched for a few minutes after, especially that first shot. And that's very rare, and I think we have to think of benefits and risks, and we still recommend that people get that vaccine. In fact, the CDC's recommendation, even somebody who's had Guillain-Barré, and I have a patient who wrote and confirmed this with us, we still recommend getting that vaccine, that there's no evidence that Guillain-Barré will be reactivated from the mRNA vaccines. So just because I think somebody mentioned an allergic reaction they had in the past, they should still have the vaccine, but they should do it in a clinical setting where they can be monitored after the vaccine.
Yes, no, thank you for that, Andy. I think the bottom line is, if you're offered the vaccine, please take the vaccine. In terms of whether or not you will mount an antibody response to this vaccine, we don't know. And that's part of the reason why Andy is doing the study he's doing, to look at your immune responses to this. The other question which really does come up, and I did want to end by speaking to it a little bit, and there were a few questions in the chat, one is, what do we do with what we are on? So if somebody is on daratumumab plus Revlimid or pomalidomide, can I get the vaccine? Somebody who's on pomalidomide. So in general, the work we've done with your immune system and vaccinations is the IMiDs, the immunomodulatory drugs, actually could augment your immune response. There are certain drugs like steroids we would say is immunosuppressive and might mask it a little bit. Our recommendation in general is to continue your treatment as you are with your myeloma. If you are in an IMiD, you don't really need to stop that IMiD and get the vaccine. If you're on dexamethasone and you can hold the dexamethasone for a couple of days around the vaccine, that would be recommended. And if you can get the vaccine in your week off of treatment, that's even better. But control of your disease is going to probably give you your best chance of mounting that immune response. And I think what's going to be really important is Andy's study is going to be able to tell us whether the 2 doses are enough, or do we even need more, like he's shown with his flu studies. A couple of other questions on, would you get the Pfizer, Moderna, or would you get the J&J vaccine? In a pandemic, I don't believe we're going to have a choice. Get whatever you get, because even a 65% chance of protection from COVID is really, really important. And that's the only way that we're going to be able to control this pandemic. And finally, I think there was one very interesting question that somebody asked, and hats off to that person, with this new mRNA technology that we have now for COVID-19, can we use that same platform in the treatment of multiple myeloma? I think that is an awesome question. And absolutely, given that this technology is being used for viral vaccines, we can actually create tumor vaccines as well. We already have studies where we're using peptide vaccines in the smoldering myeloma space, but the same vaccines can be theoretically used in the myeloma space. So let COVID get over and we'll focus our attention on myeloma. So with that, because it's at, we've crossed over beyond, but thank you all for joining. And, depending on your feedback, we're going to send you guys a survey. If you really like these, we'll do shorter versions of these over the course of the next year as well. And Devin, a huge shout out to you guys from your group. Thank you for helping us set this up. And thank you all for participating. Have a good afternoon.
Bye, everybody.